There really has not been a lot of movement for carotid stenting for quite some time. Disappointingly so, and really disappointing in the industry isn't moving forward a lot with technology because of the lack of reimbursement. I will say for the first time in a while, I believe that that may change and that there's some positive signals out there. Viva convened a Vascular Leaders Forum in Washington, D.C., attended by regulatory from the U.S. and a multidisciplinary group that really is coming out from the consensus paper. And I think with the data out there, now that we have 3 North American randomized trials, the older Sapphire trial, Act 1, and CREST, and then even more CREST 10-year follow-up, all showing equipoise equivalence essentially of the 2 therapies, I think that there is more movement to consider reimbursement for carotid stenting, which should propel the field forward even that much more. I will also say that there are newer technologies that are helping a lot as well. There are 2 micromesh stents, either who have completed trials or are ongoing, that offer some potential promise. There's a lot more adoption of proximal embolic protection, which we think has some advantages. And finally, there's TCAR, which really has exceedingly low event rates as well. No, we shouldn't do away with transfemoral. TCAR is a great technology, no question. We do it. It avoids manipulation of the arch. It has flow reversal rather than flow arrest, which is good, and allows really protected stenting. That said, there is a long history of success with transfemoral carotid stenting. Okay, again, 3 randomized trials we talked about. And registries of 50,000 plus, and it is a good technology. I think they are both good therapies, and I don't believe that everybody needs a TCAR. If they have a good arch and a good operator who can access that arch, you may not need the extra expense and cost of some degree of anesthesia, a neck incision, a little bit longer and more expensive case, etc. They are complementary therapies. We should be able to choose which one is best for the patient based on the experience. And quite honestly, I think it is far better to have a transfemoral stent by a very experienced operator, as long as it's a good arch for that, as compared to a TCAR by an inexperienced operator. I think we have to really get the best of both therapies. They're both very good therapies. We should individualize it, but not do away with one based on the success of another, remembering that Roadster 1 was 141 patients, okay, done in very high volume centers. So you can't do away 10, 15 years of success for a 141 trial, but rather supplement with this new therapy added to our armamentarium. I believe that it needs to be done in appropriate patients with the right form of protection by experienced operators. I think folks who use case selection and good technique, carotid stenting should be here to stay, and it's proven, I think, to be equivalent to carotid endarterectomy, again, provided experienced operator and good case selection. There have been many people smarter than me that have come before me to try to answer that. But my own feeling is that if we could couple it to accountability, in other words, only experienced operators can do it with adjudication of their cases, and if you tie their reimbursement to that adjudication and proven experience, I think there's a reasonable chance. I think that if we let it go unregulated, it is less likely to be widely reimbursed, probably for good reason.